Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll,
Here.
Senator Elkins, Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, Senator Wise,
Present.
Chairman Meredith, Chair Douglas.
Present. We do have a quorum, and we are duly constituted to conduct business this morning. This is meeting number 6 of the Health Services Committee. For those who, if you don't wish to stand, there is some room in the overflow room in 131. You're welcome to attend the meeting through that room. We will start out the meeting, and my apologies. We will start out the meeting looking at Senate Bill 297, an act relating to all-inclusive care for the elderly. Is Senator Storm here? If you would just bring yourself and the persons up. Senator Storm, before we introduce everyone, I want the committee, and I hope the committee has looked at the proposed Senate Substitute 1 to Senate Bill 97, and I need a motion on the. Do we have a motion? And do I hear a second? And I hear a second. All in favor, say aye. Aye. All opposed? The proposed Senate Substitute 1 is adopted, and with that being, it's passed with favorable expression. With that being said, if you'll introduce your guests.
Thank you, Mr. Chairman, members of the committee. Brandon Storm, Senator of the 21st District.
Tracy Markert, Vice President with Hospice Health, in charge of Care Guide Partners PACE operations.
Thank you so very much, and welcome to both of you all. Senator Storm, we are really looking forward to what you have to present this morning, and if you would, just proceed.
Thank you, Mr. Chairman. Members, Senate Bill 297 with the committee substitute basically had a technical change regarding the initial bill, which omitted the CON language. For those of you that aren't familiar, PACE stands for the Program of All-Inclusive Care for the Elderly. It's a federally designed program which is the type of home and community-based services to provide medical and social services to nursing home eligible elderly individuals. Senate Bill 297 clarifies that additional licenses are not needed, which reduce the burdens on PACEs as well as the cabinet. PACEs already must operate under a three-way agreement with CMS and the state, as well as the PACE program itself. The federal requirements are stringent and are to require surveys and, if needed, corrective action plans and penalties for noncompliance. In addition, Senate Bill 297 enables PACE programs to access the care systems to run background checks on staff to ensure patient safety. That's the bill in and of itself, and I'll let my guests speak.
Motion.
I hear a motion on the bill. Do I hear a second?
Second.
There's a second.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll,
Aye.
Senator Douglas,
Aye.
Senator Elkins, Senator Funky Fromeyer, Senator Nemes,
Aye.
Senator Tishner, Senator Wise, Chairman Meredith.
Aye. The ayes are the ayes are 8. The nays are 0. Your bill will pass the committee with favorable expression. Do I hear a motion for consent? I hear a motion. I hear a second for consent. All those in favor, say aye. Aye. All those opposed? Senator Storm,
Yes,
I know
Mr.
you
Chairman.
probably had a wonderful presentation that you wanted to give to us this morning, and I apologize that we were rude to you.
You were
but,
not rude, Mr. Chairman.
Your bill will be on consent. Thank you very much.
Thank you very much.
And thank your guest.
Thank you, members of the committee.
I will be handing the gavel over, as much as it pains me, to our chairman.
Thank you, Senator. Appreciate that. Next bill we'll be hearing is Senate Bill 239, which happens to be Senator Douglas's bill. Apparently, this one takes a village, right? Let me kind of set some parameters on this before you folks introduce yourself. We've got 3 bills that we have to hear today. Also, a Senate concurrent resolution, which we will not find time for, but there will be a hard stop at 10 o'clock today. So that ends Senator Douglas. I would like to kind of conclude discussion on this bill by 9:30 and give us time for those other 2 bills. So again, just not for your point of information, but anyone who may be here to speaking on behalf of the bill, for or against, we will have a hard stop at 9:30. So if you would, please introduce yourself for the record, as well as your guest, and feel free to proceed.
Thank you, Mr. Chairman. I'm State Senator Don Douglas, District 22.
Lindsay Cox, registered nurse.
Dr. Bill Werman.
Greg Chaffwin, legal counsel with Alliance Defending Freedom.
Will Southall, 4th-year medical student at the University of Louisville.
Glad to have you here this morning. Please proceed, Senator Douglas.
Thank you, Mr. Chairman. Good morning, Mr. Chairman and members of the Senate Health Services Committee. I really want to thank you all this morning for hearing this bill. This is a workforce bill. This is a healthcare worker recruitment and retention bill, and I'm not interested in anyone changing what the bill is. There's no doubt that we have a quickly changing environment here in the healthcare area, and we need to keep up, especially here in the Commonwealth. This bill, enacted relating to recruiting and retention of medical professionals, is meant to be another step in the direction addressing our healthcare provider shortage here in the Commonwealth. Ideally, we would love to have 100% of our population here in Kentucky having a primary care physician. But the truth is, some of the most recent data from the CDC suggests that only 74% of our population actually has a primary care physician. And the University of Kentucky, in their study in 2021, suggested that in the Commonwealth, we would need to increase our healthcare providers just in the physician space by 237 positions each year alone, when we're only bringing in about 116 per year. And that's just to meet what is considered the national median by 2025. And what's even worse is that 40% of Kentuckians live in a rural space, but only 17% of our primary care providers live in that space. We know the problem's multifactorial, but the issues is likely to worsen, especially now that we see a number of our hospitals consolidating, and they're getting rid of their regional outreach clinics, and they're bringing them to the more urban areas. And my concern is that it is bringing healthcare further away from some of those patients who need this the most. Now, the truth is, academic studies cite a lot of reasons for the changing healthcare landscape. But having been in the healthcare space now for over 40 years, I've had multiple conversations with people in the corporate space as well as people in the private care space. And many of them cite the loss of autonomy in their practice, the loss of control of their practice, the inability to make independent decisions not run by standard protocols, as reasons for causing frustration, increasing their stress, and ultimately leading to burnout and the decision to leave their medical practice. Our current healthcare model is really of a concern to me. How do we address the private practice versus corporate practice concerns? Well, this bill is designed to help start restoring some of the balance in our healthcare space. We want our healthcare providers, we want to make sure that we afford them the same rights and the same ability to respond to inconsistencies in the medical practice space as other people in the general public have, knowing that their rights are supported by this law, Mr. Chairman. The concern that healthcare providers will simply decide not to see certain patient groups, it's not consistent at all with healthcare provider mentality or healthcare provider actions. And this bill doesn't alter any of the emergency responsibilities that may be needed. This bill is really meant to send a message to those who are considering living in the Commonwealth and staying in the Commonwealth and practicing in the Commonwealth by saying, you are welcome here. You will be fairly treated. And we value your decisions as a physician. Mr. Chairman and members of the committee, this bill, for those who might think it, is not a fix. But it is a step toward leveling the practicing field, and I mean the practicing field, for those wishing to come to the Commonwealth. My last question is this. Would we look at this any differently if it didn't say healthcare worker, but it said baker or an engineer or social worker? We shouldn't look at it any different. This may be a small step, but it is a step in the positive direction. Now, I'm going to turn this over to some of my presenters who may want to have some things to say, or they simply may want to answer your questions. But I thank you for your time.
Good morning, Dr. Bill Werman. 18 years practice emergency medicine. Last 14, St. Joseph, London. 12-hour shifts last 2 days, getting off at 11 last night. I just want to testify the healthcare professional shortage is real. See it regularly. Each morning, our daily huddle in the ER, we go over what specialists do we have. We haven't had a GI specialist full-time in years. Often no neurology, no podiatry, and that affects how we're able to care for patients, increasing having to transfer patients to other facilities. Regularly, nursing shortage means we're told we don't have beds available in the hospital, but really that means more often we don't have the nurses to staff those beds. And our hospital is just one example, and that's in other hospitals, same problems. More and more people use the ER for their primary care. And I believe them when they come in and say, I call my doctor and says I can see them, next month or the month after that. And that's just not adequate. And but they come and see us. So seeing that lack of healthcare provider out there as well. So I see this bill is a step in the right direction, a help to the situation. And I just want to make one other comment about that this bill would not result in any denial of care to any patients. I've worked ER for 18 years. I've never seen any patient be denied care. People, providers, they take care of the people that come. I mean, yes, we have EMTALA, but people get cared for. Nobody gets turned away, and that will never happen. So I just wanted to mention that. So finally, I just wanted to say, ask you to support this bill. I think it will strengthen the Kentucky healthcare system and support the healthcare professionals who are currently practicing and will in the future choose to come here, and ultimately maximize care for patients. Thank you.
Hello, everybody. So I'll just say that, this bill helps doctors and patients by respecting doctors' oath to do no harm, and it ensures that medical professionals can care for their patients.
Excuse me, I hate to interrupt your presentation, but would you identify yourself for the record again, please?
Sure. Greg Chaffwin, legal counsel with Alliance Defending
Thank you,
Freedom.
appreciate it.
Yes,
Sorry.
sir. So the bill, as I was saying, helps doctors and patients. It respects their oath to do no harm, and it ensures that medical professionals can care for their patients without being forced to do procedures that violate their conscience. Surveys show that 9 out of 10 religious medical professionals would sooner leave the profession than violate their conscience, and 1 in 5 medical students have already changed their field of study because they were concerned that their conscience rights would not be respected. We know that patients are best cared for when doctors and nurses can speak freely and are not forced to perform procedures that violate their oath to do no harm. Most patients consider it very important to find a healthcare provider who shares their values. We know that America is a diverse society, and there is room for all sorts of different viewpoints in the medical community. But in order to have that diversity and variety of opinions, medical professionals need to be free to speak and free to act according to their conscience. So to close my comments in respect for the time we have, I could say more, but I'll reserve that if there are any questions. I would just say that this bill is well tailored to work in practice. It's similar to laws that have been passed in 7 other states for many years, in some cases more than 40 years. And no one should be forced to choose between their faith and their profession, especially not our doctors, many of whom are inspired by their conscience to help others. Thank you.
Do I have more time, Mr. Chairman?
Excuse me, I think we have about 3 minutes.
My name is Lindsay Cox, and I am an emergency nurse. And I'm here today because my own career was impacted by a lack of protection for conscience protection. I was a student in nursing school, and I changed the direction of my career because I was worried that I would be forced into providing and participating in procedures that would violate my own conscience. I hesitated to enter into the field as an obstetrics and gynecological nurse because I was worried that the state of Kentucky was not going to protect my rights or respect that I have a conscience, and therefore put me in the position of violating that. I know many of my peers and colleagues as nurses feel similarly, and I would just encourage you today to support this bill. As healthcare professionals, we need support, and we need to know that if a patient comes to me, I will not deny them care, and I want to reiterate that. We do not deny care in the emergency room. We take care of patients no matter their background. I love taking care of patients. It's my passion. That's why I'm here. But I need to know that I will not be put in a position where I would have to violate my own conscience. Thank you.
Will Southall, fourth-year medical student at the University of Louisville. In 2 months, I will graduate from medical school and begin my journey as a physician. Where I choose to practice is heavily influenced on how the state protects me and my rights to have my own conscience regarding how I provide care. This bill is important for me and my colleagues who are going to be the next generation of physicians in Kentucky. Should we stay, or should we go to a different state that protects us more? Thank you.
Thank you. I appreciate you being respectful of the time. And we do have several people who have signed up to speak in opposition to the bill. I'd ask you all to kind of excuse yourself and hang around because we'll do questions after everyone has presented. As I noted, we have several people who have signed up to testify. We have about 12 minutes left, so we're going to ask everyone to limit your remarks to 2 minutes each. Please don't be redundant. If somebody says something and you aren't in agreement with that and you can't add anything to the discussion, please just excuse yourself from the listening. But I'll start in the order that we received the request. First, Mason Kalinsky, if you would, please come to the table. Again, you'll have 2 minutes. If you would, identify yourself for the record. No. Green light should be on.
Hi, my name is Mason Kalinsky. I am here to testify against Senate Bill 239. I agree with the intention of the bill that Kentucky does have a crisis for medical providers. I have a lot of friends in Eastern Kentucky who I've talked to about the state of medical care. One of the things they've told me is how much of an ordeal it is to get care, especially to get specialist care. Senator Douglas cited that there's a shortage of rural doctors. 43 of our 120 counties are lacking primary care doctors. 72 of our 120 counties don't have OBGYNs. So for my friends, they've told me they have to find childcare for their kids. They have to take a whole day off work. They have to drive sometimes as much as 3 hours to get into Lexington and Louisville. And it becomes a whole day affair for them to see care that they need to see. And my concern is that this bill would make that even harder to see a doctor that would give them the care that they need. If a doctor is able to object to something that is within the standards of care for the medical conscious, that would just be another barrier to my friends in Eastern Kentucky seeking care. Thank you.
Thank you. Appreciate it. Bob Hellringer. Good to see you, sir.
Morning,
As always,
Mr. Chairman.
appreciate you
Good
being
to
here.
See you. Members of the committee, I'm Bob Hellringer for the record. I'm an attorney in Louisville. I'm a registered Republican. I live in Senator Armstrong's district, 19th Senate District, precinct G160. For 23 years, I served in the House, and every day of it on the Health and Welfare Committee, as it was known. So I know the unique challenges of this committee. And I'm also very proud to represent the Fairness Campaign, okay, the organization that advocates that our gay citizens in Kentucky that live in your district and all over Kentucky are treated fairly and are not discriminated against, which this bill does. Let's drop all pretense. Some of the testimony here has been very interesting. Nobody that's for this bill is for the denial of any care. And yet, Mr. Chairman, members of the committee, on page 6 of the bill, a medical practitioner, healthcare institution, or healthcare payer shall have the right to not participate in or pay for any healthcare service which violates his, her, or its conscience. That could directly result in a denial of care based on someone's conscience. Well, what's that? Well, it's any sincerely held belief. They don't like gay people. They don't think they should be treated when they're sick, so they don't want to participate. That could happen under this bill. If this becomes law, it will happen. It will happen in Kentucky. And that's a shameful thing. That's a shameful thing. I would ask the committee respectfully to, if you can't vote against the bill, to pass over it. That was an option we used to have and when I was here.
Thanks, sir.
And
2
study
minutes.
it. Yeah, still.
2
And-
minutes.
Yes, sir. Still find out where there's a need for this bill in Kentucky. Listen to some testimony, okay?
Mr.
I don't
Hellringer,
see any
Your time has expired.
organiz-
I wasn't giving
2
you
minutes?
two additional
That was
minutes.
a quick 2 minutes.
Well, that's what it is when you
2-minute
sit at the
rule.
microphone. But
Thank you,
I
Mr.
appreciate you
Chairman.
being here.
Appreciate your time.
Next is Tamara. Is it Weeder? Ms. Weeder, if you would identify yourself for the record in 2 minutes, please.
Good morning. My name is Tamara Weeder. I'm the Kentucky State Director with Planned Parenthood Alliance Advocates. Thank you for allowing me to testify in opposition to Senate Bill 239. When healthcare providers are allowed to deny care and information, patients are put at risk. This bill allows delayed and substandard medical care with no protections to ensure patients get the care they need. This will harm Kentuckians, especially people who already face barriers to accessing care, such as people with low incomes or people living in rural areas who can't obtain care elsewhere. All people in Kentucky should be able to access the care they need when they need it without fear that their provider or insurance plan will withhold evidence-based care or information. But this bill is so broad that any person who participates in any healthcare service in any way could object for essentially any reason so long as the person claims it goes against their moral beliefs. A pharmacist could refuse to dispense antidepressants. An insurer could refuse to cover certain types of birth control. A receptionist could refuse to admit a patient experiencing a life-threatening miscarriage to a hospital because they do not want to participate in end of pregnancy care. An ambulance driver could refuse to take someone to the hospital because of their religious preferences or because they own a gun, which violates their morals. This bill even allows people and institutions to deny care based on an objection to the patient themselves, such as denying contraception to an unmarried woman or refusing to provide pediatric care to a child with gay or lesbian parents. Healthcare entities should not be able to pick and choose who gets to receive critical Medicare based on personal or religious beliefs. Even worse, this bill allows those who refuse to provide care to sue if their so-called conscious rights are violated. You know, we heard that this is stopping, people from looking to Kentucky for coming, to fill the doctor shortages. But I talk to providers every day who are leaving the state now because of the laws that we have passed the last decade on reproductive health care. We really need to think when we have 72 counties without providers. Thank you.
Thank you. Next on the list is Michael Frazier. Again, if you would, please identify yourself for the record and remember 2 minutes.
Ladies first. Okay, sure. Hi, I'm Rebecca Blankenship. I'm the Executive Director of Band Conversion Therapy Kentucky. Michael Frazier and I work together. I think that Mr. Frazier is going to talk to you in a minute about what I think is a totemic example of how this bill could go wrong, conscience-based medical malpractice, and that's conversion therapy. Which I think would be pretty explicitly permitted if this bill is enacted as written. But I want to draw your attention to 3 other concerns as well before we begin to talk about that, okay? So our talk today, I think, is going to be centered on Section 5, subsection 1 of the bill. The intent, I think, is to make sure that it's First Amendment protected content that is shielded here. But I'm worried that the language as written may inadvertently be broader than that. The first reason that I have for that is this reasonable doubt standard. Okay, that's the standard in criminal proceedings, not in civil and administrative proceedings. You could have an instance under this bill where somebody could be found responsible for example, gross medical malpractice, intentional infliction of emotional distress, or fraud in a state court, but could not have their medical license taken away because the evidentiary standard is higher. There's also the word otherwise, okay, that's a really serious issue. The word otherwise is included in this bill, has the potential to import First Amendment context that is not appropriate to a doctor-patient relationship. I can go on YouTube and post a 90-minute video claiming that cell phone towers cause polio, and that's First Amendment protected, but it's not when a doctor does it. So the ambiguity created by that word otherwise, I just think that we should strike it. The third thing is that the standard of physical harm, okay, is a real issue here, okay? The standard of physical harm that's in this bill forecloses any emotional or economic harm from being a cause of a license being revoked. And I just want to note, yes, sir, just one last sentence, that the state of Kentucky does not recognize an unborn fetus as being protected by the standard of physical harm in civil and administrative proceedings.
Sorry, Michael. Time.
Yep. Okay.
All right. Thank you all.
Thank you.
And just to be clear, we only oppose Section 5. That's the provision that we believe that may legalize conversion therapy. We do believe that this is a workforce. There is a healthcare shortage. We want to protect our workers. But we do also recognize that people will not want to live in a state that protects conversion therapy.
Number one issue.
Again, we're just running slightly behind. I'll leave the last presentation, comment, testimony to Lori Grimes. If you would, please come forward. Again, please identify yourself for the record in 2 minutes.
Good morning. Thank you, Chair Meredith and committee. I'm Laurie Mount Grimes. I'm a pediatric psychologist, and I'm here today representing the Kentucky Psychological Association in opposition to SB 239. In a time when our nation, state, and local communities are trying to improve access to care, overcome the barriers to care of marginalized communities, expand mental health services, and attract and retain a competent healthcare workforce, along comes SB 239, a bill so broad in scope, so vague in definition, so lax in accountability that it will overtly sanction discrimination in statute. KPA is opposed to SB 239 based on these discriminatory effects and for the secondary impact on mental health and suicidality, because people who are deprived of health care based on arbitrary grounds and unchangeable personal characteristics, whose personal autonomy is usurped and their personhood harmed, will experience a detrimental impact on their physical and mental health. SB 239 extends the reach of restrictions beyond the healthcare provider to allow discriminatory gatekeeping from office staff, technicians, or any employee of the facility, as well as payers. A person's access to vital medical care could be interrupted and blocked from the point of completing paperwork to having blood drawn or any other point in the process based on how someone looks, sounds, dresses, advertises their political affiliation, sexual orientation, or any other factor. The bill offers no limits, safeguards, or protection for patient well-being in the face of these insults and restrictions, and prioritizes one person's belief over another person's personhood. This will create particular challenges for mental health care where access is already difficult. Effective mental health care requires trust and openness between patient and provider. SB 239 creates conditions where that trust will be difficult or impossible to achieve. I'm skipping ahead to my summary.
You don't have to. It's 2 minutes.
Oh,
I'm
shoot.
sorry.
Okay, well, thank you for your time.
Thank you. We're running just a little bit behind. I'd ask Senator Douglas to come back to the table and provide a 2-minute summation.
Thank you very much, Mr. Chairman, and thank you, members of the committee. We all in the legislature know there is no perfect bill. We also know that, at least in our country, you have a choice in which providers that you want to see. You know, physicians as a group are not activists. We're healthcare professionals. We're not ditch diggers. We're not plumbers. We're not a lot of things. We spend a lot of time learning to do what we do, and we do it well. We hear people talk about lifestyle all the time and how we won't treat people with certain lifestyles. Well, I've got news for you. We don't like people who smoke all the time. It causes chronic obstructive airway disease, lung cancer, various other things. We don't want people to do overeating. It causes obesity. Promiscuity leads to a lot of things. We don't choose not to treat those patients. To believe that the healthcare worker in this space is all of a sudden going to decide, I'm not going to treat people? Really? We are physicians. This is what we do. But we're also citizens of the Commonwealth of Kentucky, and we're citizens of this country. And we should have the same right as anyone else who is in this Commonwealth or anyone else who is in this country. The concerns of, again, loss of care, I get it. But this won't narrow your care. Some people look for barriers when no barriers exist. I assure you, as a black professional, there were a lot of barriers. But there are also some barriers that were in my mind that I had to overlook because they were things I was scared about, but they weren't really there. And I can't blame others for the barriers I create for myself. Again, Mr. Chairman, there are no perfect bills. I'm happy to sit down and look at reasonable changes. But this is something we need here in the Commonwealth if we're going to start a baseline and be serious about improving our healthcare system here in the Commonwealth. Thank you, Mr. Chair.
Thank you, Senator. I'm going to suggest, Senator Douglas and I had a conversation much earlier this morning about this bill. We understand the importance of it. I agree with him. There is no perfect bill. I think there are some opportunities to make some changes to improve it. And what I'm going to suggest, Senator, is that rather than take a vote today, because we have a lot of people that have questions about this, I'd ask our committee members, if you would, keep those questions, give some thought to these presentations you've heard today, and let's come back next week, and not for testimony, but just for question and answer, and take action on the bill at that time, if that is agreeable.
Thank you, Mr. Chair, and thank you, members of the committee.
Thank you, sir. Appreciate you presenting the bill. Next on our agenda is Senate Bill 280. And probably we're going to do this one a little bit different in that we have 280 and 281. Please, Senator, come to the table. And they kind of overlap a little bit.
Yes, Mr. Chairman, I think that's a fair statement.
So we'll take them in totality and try to address it from there. But if you would, Senator, glad to have you here this morning. Identify yourself for the record, and as well as your colleague there. It's good to see you.
Yes, Mr. Chairman, Senator Philip Wheeler, 31st Senate District, Pikeville, Kentucky. It's a pleasure to appear before your committee here today.
Senator, before you proceed,
yes.
just let me let the committee members know that this is being presented today for only as well. Okay. Thank you.
Thank you, Mr. Chairman. It's an honor again to appear before your committee. I know that you yourself are a strong defender of rural health care in the Commonwealth of Kentucky. And as the senator for the 31st District, I'm proud to have one of the state's leading health care providers, Pikeville Medical Center, located within my Senate district. I think many of those on the committee had the opportunity to visit Pikeville Medical Center and see the great strides that it's been making during our caucus retreat this past December. And I'm proud to have Donovan Blackburn here with me today, who's the president and CEO of Pikeville Medical Center. Mr. Chairman, as you've stated many times before, rural health care is in a crisis due to a variety of circumstances, particularly with the loss of jobs. It's becoming more and more difficult to provide quality health care on a sustained basis to a population that is increasingly impoverished and without jobs. Many hospitals, including Pikeville Medical Center, are forced to rely on Medicaid as the primary payor, and this has created some fiscal situations that rural hospitals are struggling with. What Senate Bill 280 and 281 intend to do is, we have seen in the last, I'll take them in order. Senate Bill 280 is a bill to allow Pikeville Medical Center to expand the scope of its service to the community, particularly by partnering with the University of Pikeville, which holds the third medical school, license for the third medical school in the Commonwealth of Kentucky. It provides numerous physicians for our community, and many of those physicians end up staying in rural Kentucky after they go to that school. What Senate Bill 280 would do would be to allow the additional resources under the state's university rate to Pikeville Medical Center if they partner with UPike in order to support residency programs. Clearly, when you have doctors practicing in the community, they form relationships, and the more relationships that they have, the better possibility we have of staying in rural areas. But, residency programs come at a cost, and, that additional cost is not sustainable under the current reimbursement rate sustained by Pikeville Medical Center. Donovan could speak more to this, but there have been conversations with the Cabinet for Health and Family Services as well as Congressman Rogers' office over the last year that it would be possible to expand the university rate currently being received by Kentucky's other teaching hospitals, the University of Kentucky and the University of Louisville, to Pikeville Medical Center through a requested waiver through CMS. We believe that this would facilitate the establishment of these residency programs in conjunction with the University of Pikeville by allowing that additional revenue to flow to that hospital. I guess I would turn it over and let Donovan, he's been kind of on the ground floor of that, maybe speak to a few more details on that, but if you...
Again, it's certainly my pleasure to be here. I appreciate the opportunity to speak today. I want to start out by very briefly, most of you had the opportunity to visit our facility, but really why this came about is that Pikeville Medical Center is a regional facility, is a transfer hospital also. We received transfers last year of 48 different hospitals throughout the region. We are a higher level of care. We have great partners in the region, such as ARH, that we do a really good job at collaborating together for the betterment of the region. But the services that we offer is a lot of specialty, subspecialty on top of a normal surgeries, et cetera, that you would see in a hospital such as ours. So when you look at what's happened over the past several years with the relationship with the University of Pikeville, 3 medical schools, as the senator said, so we have, in essence, become a teaching hospital. We are not only directly connected with the University of Pikeville with the medical school, also the optometry school, and soon to be a dental school. We do most of the clinical rotations through an interlocal agreement that we have. But it goes beyond that. We also have 2 two-year technical schools that's actually on our campus, on top of the university, and Big Sandy Community and Technical Colleges also has 2 schools within a half a mile of our campus. So we have currently about 350 two-year programs that's doing the residency programs or their rotations, within the walls of our hospital. And that's important for Eastern Kentucky because, as you heard earlier today, everyone knows that there's a huge workforce crisis in healthcare in general, specifically even with providers. When you look at the recent Becker's report, they've forecasted around 124,000 physician shortfall by the year 2035. Realizing there's 3 medical schools within the state, having the opportunity of presenting programs that we would be able to partner with the university with is extremely important, not just to Eastern Kentucky, but for the whole state. So looking at the totality of who we are, what we offer, and what we do, a conversation was actually started a few years back with UK. UK has been a great partner of ours, and this is certainly not an issue between UK and PMC. This started because of all the things that the Senator mentioned, along with the things that I'm talking about as well. So we actually made a trip to UK. It's been about 3 years ago when the university rate was first being discussed, when Mark Newman was in place at that time. And we talked about the possible opportunity of forging some type of relationship that would benefit the hospital, our hospital, to where we could actually expand and look at more residency programs to be able to support that need. A partnership was formed. We started working together on pediatrics and some other services as well. But the main intent of that discussion, which led into discussions with the governor, Senator Stivers, Hal Rogers, and then CMS. So we were able to forge forward over the last year and a half in working with CMS and the state cabinet. And in sincerity, up until about the 1st of January, we thought we had both the CMS and the cabinet's support, only to find that we received an email stating that the cabinet was no longer in favor of a support letter in supporting this, and that CMS kind of went blank on us for a short period of time. So I'm going to take a brief pause. That kind of brings you up to why we're here, or why this request was here, and kind of how that we ended up getting involved with this particular request.
Thank you. Just a reminder, we've got about 15 minutes left, so we got another bill to cover, and I'd like to hear from some folks that want to speak.
Well, I'll go ahead and talk a bit about Senate Bill 281. Senate Bill 281 is kind of more of a responsive measure to some recent actions by the University of Kentucky involving the purchase of hospitals in rural Kentucky. Approximately 3 years ago, they purchased King's Daughters Medical Center in Ashland, Kentucky, and the issue with the expanding footprint of UK in rural Kentucky is that they are coming in with a competitive advantage to the other healthcare providers in the region. When UK acquired King's Daughters Medical Center, they also acquired it with the enhanced university rate that we were talking about, such that King's Daughters Medical Center was able to go from a rather large deficit to a $100 million surplus within a year based purely upon the reimbursement rate. Now, I will tell you some of the issues regarding the reimbursement rate are rather obscure, and it's difficult to get information about it, but given that massive swing in revenue, you can tell that it's substantially larger than what the average healthcare provider receives in rural Kentucky. This is where that's a problem. Clearly, when UK expands out there and purchases these hospitals, and there's this huge influx of cash, they have greater possibilities to advertise, recruit physicians, pay higher wages, which puts our local hospitals at a competitive disadvantage. If they are to try to meet those wages, then that creates systemic issues in their operations because they cannot afford to compete on a dollar-for-dollar basis because they do not have that enhanced university rate. And overall, this drives up the cost of health care since they're able to offer the higher wages that our local providers cannot do. This is problematic in the sense that what we fear is that not only are they purchasing these hospitals, they're opening up clinics right on the doorstep of other hospitals within the area and drawing patients away. So instead of referrals coming, for example, out of ARH to Pikeville Medical Center, or even I think some other hospitals have been identified that are currently referring to local providers, those referrals are now going down to Lexington, Kentucky. This leads to a further drop of revenue for our local healthcare providers. Over time, this creates a significant crisis in healthcare since the money, instead of staying local in the economy with those healthcare providers, will obviously will flow down towards central Kentucky merely based on this competitive advantage reimbursement rate. So what Senate Bill 281 says that, sure, we respect UK as a teaching hospital, we respect U of L as a teaching hospital. We want Pikeville to be a teaching hospital, and there is certain financial needs as a result of that. But if UK or if U of L or if Pikeville, if Senate Bill 280 is passed, choose to travel outside of the county or the area where their local hospital is operating, they should compete on the same basis as every other healthcare provider in the region. So what Senate Bill 281 does is it limits the enhanced university rate to the actual county or area where their university hospital is located, which places the universities on the same level as far as competition in rural areas as our local providers. Again, it's nothing against UK. It's simply placing them in a similar position in rural Kentucky as our rural healthcare providers that we are desperately dependent upon for jobs. As Donovan can tell you, he employs over 3,000 people. If that hospital were to close, it would cause just economic devastation in my hometown. And,
Allow me to say, Senator, duly noted. I think the essence of the argument is UK has a competitive advantage over other rural
Yes,
hospitals
sir.
because of the enhanced rate. And to that end, I'd ask the folks from University of Kentucky if they want to come forward and speak to this. We'll continue. But, Senator, appreciate your presentation. Again, we'll continue this discussion later, I'm sure. And the legend Mark Birdwhistle comes to the desk. If you would, sir, we all know you, but for the record, identify yourself for the record.
Yes, it is good to be back in Frankfurt, I think. It's been a while since I've been here.
Please identify yourself and make sure the light's on. Is it green?
Now it is.
Now it is, yeah.
Technology is not my thing. Medicaid policy is.
Gotcha.
Thank you for the opportunity to be here. My name is Mark Birdwhistle. I am currently the Senior Vice President, Chief Administrative Officer of UK Healthcare, and have spent the last 45 plus years working in Medicaid policy, either at the state level or at the university. I understand we're here to talk about Medicaid directed payments. There are really two different paths to Medicaid directed payments. There are the university path, which was the first one. Then there's the private hospital path, which was the second one. It's known as ATRIP. Both of these plans are authorized by the Medicare Managed Care Rule of 2016. They are all focused on improving access and quality. And I'm here to say these plans are working. These plans are working, and they are improving access, they're improving quality. I will say, on behalf of UK, I acknowledge we've had some missteps. We've had some miscommunications and misunderstandings that has led to the concerns that brought Senate Bill 280 and 281 to the table today. We have begun diligently working on those issues. We understand marketing, billboards. As I've explained it to others, when you put the UK brand in front of King's Daughters, it takes on a different level of partnership. And we need to manage that and make sure, because the UK way of dealing with partnership is to go into the community and say, what can we do to help you be successful? What can we provide? We have lists of things that we are partnering both with Pikeville and ARH. Donovan and I have started talking in the last couple of weeks. We kind of dodged each other for a while, but we decided that wasn't serving either one of us well. So we're now talking about every other day. Got an extensive meeting with Holly and her team tomorrow to talk about how we work together. My concern is these plans are approved. The ATRIP plan, the KHA plan is approved through December 31st of 2024. The university plan is approved through December 31st of 2025. If these bills pass, in my professional opinion, that would trigger amendments to both the 24 and the 25 plans. And I don't think that's in the Commonwealth's best interest. And for that reason, we have to oppose these bills. Because these plans are working, we've got a golden egg in that these plans are approved. Let's work as provider partners and get back rowing the boat the same way to improve the care of Eastern Kentucky. Now, I know there are maps. I understand they're in your folders. My phone blew up yesterday with all of the maps that were circulating. There's two perspectives on those maps. In my initial look, I know the depiction is to try to say UK is taking over Eastern Kentucky. My perspective, one of the missions of the University of Kentucky is to serve the patients of Eastern Kentucky. I can go through each one of those dot points and tell you the stories of why those dots are there. The Hazard Center for Excellence in Rural Health was approved by the General Assembly in 1990. That's not predatory. That was legislatively mandated. We have generated over 100 graduates in these programs, not just in family medicine residency, but in social worker, physical therapy. And I could go on and give you the stories. I understand your time constraints.
To that end, Mark, if I could, can you speak specifically to Senate Bill 280? Does UK have an issue with what Pikeville's trying to accomplish with
yes,
that particular bill?
So 280, I think both of these bills would trigger. Now, 280 has a lot of questions to it. The questions are, when it talks about the rate, what rate are they talking about? Is it their normal Medicaid rate? Is it their DSH rate? Is it their directed payment rate? What does rate mean? Is it the gap payment? And I will say that UK has received the average commercial rate since 1994 on the physician and the professional services. That's what has enabled us to improve access in the region. When providers would call us in Manchester, there were no optical care providers. UK was called. UK answered that call. King's Daughters. There was a global pandemic hitting us. Our Lady of Bellefonte closed their doors. UK was called. UK responded. In Bowling Green, there were no orthopedic physicians to support the hospital. UK was called. UK responded. That's where I want to get back to, and we are committed to that. But to close the loop on 280, I think there's so many questions in 280. I think both of these bills could trigger an amendment. My recommendation is we work in the interim with both the providers in Eastern Kentucky, demonstrate that they're where they can fit into these plans as approved before we go and do something that creates some unintended consequences. I'm personally very fearful if we put these plans under review again at CMS, I'm not sure where the outcomes will be.
Certainly appreciate that, and I know there's a lot of questions that need to be answered, and I wish we had more time to do that today. I wish that the Medicaid folks were here to talk about this more specifically, but communication is a great tool. It's a shame we don't use it more often.
And we are committed to improve communications to the provider community there.
Well, it concerns me, Mark, that every action that a provider takes has unintended consequences for others. And you make note that UK's focus is kind of Eastern Kentucky, so I'm sure Senator Carroll and I are asking, well, what about Western Kentucky? And the same thing kind of develops itself as you're building a strong network in Eastern Kentucky. That has some implications for Western Kentucky in terms of being able to compete. And I think the big issue with manpower right now, with the drastic shortage that we have, particularly our rural hospitals can be outbid, and then what do we do? Right. So this is a much bigger problem that we're all going to have to address. But again, that's why this is a hearing today. I think we do need to do much more work. I appreciate that you folks are open to the continued dialogue, particularly with Pikeville. I want to see this thing work as well. But for the committee members, this is for hearing. I'd encourage you to develop your questions, and we'll pick those up at our next meeting. And Senator, I'll commit to you, we will have this on the agenda for next week as well, and we'll continue discussion. But gentlemen, appreciate your participation today, appreciate your willingness to work and see if we can come up with a solution.
Thank you, sir.
With that, committee members, we do have Senate Joint Resolution that we're not going to discuss today. We'll hold that for a different time, but appreciate everybody's attendance and participation. With that, we will stand
Mr.
adjourned.
Chair,
Thank you.
If I may, I'd like to log a aye vote to Senate Bill 297.
Duly noted. Thank you.
Thank you.
Did you get the my meeting. Yeah, 149. Human trafficking, Department of Public Health. That's here. That's what we're relating to human trafficking, relating to advocacy, relating to. So it's in here? No, 149. 149. Sorry, you gotta go.